Hello, my dear charms. Hope you're good, preparing well for your MRCOG Part 2 exam. Introducing myself, I'm Dr. Dinesh, one of the mentor of Team Study Medics. We are going through the RRR series for the self-fertility module where we are discussing about very important exam essential topic which includes endometriosis, male infertility, premature ovarian insufficiency, and early ovarian aging. So let's start the series of the academic session. Always do your best. What you plant now, you will harvest later. And that's the reason the exam preparation is very, very important for your upcoming bright results. The topic of endometriosis. The prevalence of endometriosis, the women of reproductive age in the United Kingdom is approximately 10%, and among the women with the self-fertility is near about 25 to 50%. Endometriosis is defined as endometrial tissue, ectopic glands, and stroma found outside the uterus. New European Society of Human Reproduction and Embryology guidelines recommends that laparoscopy is no longer the gold standard. Laparoscopy should only be performed in a patient with a negative imaging and or where the empirical treatment was unsuccessful or inappropriate. As highlighted by the current ASHRAE guidelines, imaging in the form of MRI and advanced ultrasonography are considered as a first-line investigations for the deep endometriosis. The mechanism of endometriosis, which is related to the fertility, it could be because of the dyspareunia, distortion in the anatomy, the effect of endometriosis on the egg quality, the endometrial receptivity. Because of this endometriosis, the patient do undergo the pelvic surgery that do distort the anatomy, and yes, along with that, there could be a possibility of change in the ovarian reserve because as it causes the operative stress, and yes, the ovaries do lose the very important thing that is the antral follicle count because of the ovarian surgery. The 30% cases with the tubal pathology do have the endometrioma. When it comes to the endometrioma, it considered as one of the marker of more severe disease. It do have the space occupying effect as it causes an oxidative stress reaction which leads to the fibrosis, a loss of cortical stroma, a smooth muscle cell metaplasia, impaired vascularization, and at later stage it results into the reduced follicular maturation and atresia in early follicles. And that's how it leads to the subfertility and very soon to the infertility. No studies have demonstrated a higher rate of aneuploidy in the patients with endometriosis. A chronic inflammations and effect of endometrial receptivity and the progesterone sensitivity do get hampered by means of endometriosis. So it is always better to opt for frozen embryo transfer when you are performing the embryo transfer in this group of patients because there is increased induction of the P40 aromatase expression that do results into the poor IVF outcome. The staging and the scoring of endometriosis. Revised American Society of Reproductive Medicine, historically called as American Fertility Society, this scoring system is designed to classify the extent of disease and its relationship with the pregnancy. However, it does not correlate well with the pain or fertility. The NZN scoring system is applied to the preoperative imaging assessment so as to predict about the laparoscopic operating time, but it has no or very little correlation with the patient's symptoms and infertility. Endometriosis Fertility Index, which is very new, a 10-point scoring system grouped into the 5 categories of risks to predict the pregnancy rate in a woman with surgically assessed endometriosis, which are attempting for a non-IVF conceptions. So it tells you about the post-surgical chances of your pregnancy. Management of endometriosis related to the fertility. If you're talking about spontaneous conception, the ASHRAE guidance is that ovarian suppression should not be prescribed to improve the fertility related endometriosis. Laparoscopy could be offered as a treatment of endometriosis related to the fertility for early stage endometriosis as it improves the rate of ongoing pregnancy. In a surgical management, post-operative medical therapy should not be prescribed with the intention of improving the fertility, but rather reserved for the post-operative pain management in women that may not be seeking to conceive immediately after surgery with the knowledge that this is not detrimental. ASHRAE guidance is that surgery for a deep endometriosis does not definitely improve the fertility but may be an option in a symptomatic woman wishing to the conceive. If you are planning with the help of assisted conceptions, IUI with the ovarian stimulation could be offered as a treatment option. if all other factor, which includes the ovarian reserve, maternal age, patent tubes, semen qualities were favorable. The success of IUI in a woman aged over 40 is low, with the live birth rate per cycle is less than or equal to 4% in a recent systemic review, and therefore IVF should be considered the first line in this woman. In women with endometriomas, antral follicle count could appear to be more sensitive to the ovarian response than the anti-Mullerian hormone. Antibiotics are recommended as a good practice for women with endometriosis undergoing the ART, as they are considered to be the high risk of the pelvic infections. If the woman opt for the fertility preservation after counseling, she should be aware that the two main factors impacting the live birth rate are the number of oocytes vitrified and the age of patient. It is recommended that women who are less than 35 or equal to 35 years should cryopreserve at least 10 to 15 oocytes to achieve the live birth rate between 40 to 70%. More the number of oocytes, more the chances of getting the pregnancy. The treatment of endometriosis in the context of self-fertility, where if it is a mild or minimal, if you're talking about a medical therapy that includes the hormonal suppression, no improvement in the natural conception. If you perform a surgery, increased chances of natural conception and could be considered in a good prognosis patient. Important to consider the other factors such as age, ovarian reserve, tubal patency, semen quality. Subsequently, you could see that the age cutoff considered over here is 40 less and 40 above. 40 less considered to be the good prognosis, 40 above considered as the poor prognosis. So it will helpful for you to come to the conclusion during solving your questions. Assisted conception does not reduce the success of ART compared to the woman without endometriosis. If it coming into the moderate to severe, and if you're planning for medical therapy, no improvement to the natural conception, post-operative suppression prior to ART used to prevent the symptoms to recurrence, and that's the only use in the post-operative phase by giving the medical therapy. Surgery. It may increase the natural conception, but the ART has greater chances of success considered in a symptomatic woman with a previously failed IVF, balancing the increased risk of surgical complications. And it also causes the reduction in the ovarian reserve after the surgery. So it is very important to make your patient aware about a surgery in a patient of endometriosis may lead to the decrease in ovarian reserve, as we have seen that how the sequelae affects the infertility. Assisted conception is associated with a lower number of eggs retrieved and reduced live birth rate following the ART. When it comes to the endometrioma, if you talk about medical therapy, a dynogen suppression may have lesser impact of the anti-Mullerian hormone. If you think about surgery, then cystectomy carries the risk of reducing the ovarian reserve, because yes, ovarian stroma and the tissues are in the vicinity and it do get affected. Cystectomy has advantage of preventing the recurrence. Routine cystectomy does not increase the live birth rate with the ART, and consider the surgery if access to the ovary for oocyte retrieval is not possible. If you go ahead with the assisted conception, any endometriomas more than 3 cm or more than 30 mm have a significant negative effect on a number of oocytes collected. Cystectomy increases the risk of poor ovarian response to the stimulation. So these things has to be discussed with the patient. Let's go ahead with certain questions. Which of the following is a false statement? A. The extended administration of GnRH agonists prior to the ART treatment to improve the live birth rate in an infertile woman with endometriosis is recommended. B. There is insufficient evidence to recommend a prolonged administration of COC, that is combined oral contraceptives, or progesterone as a pre-treatment to ART to increase the live birth rate. The clinician should not routinely perform a surgical excision or ablation for an incidental finding of asymptomatic endometriosis at the time of surgery. In an infertile woman with a revised ASRM stage 1-2 endometriosis, clinician may perform intrauterine insemination with ovarian stimulation instead of expectant management or IUI alone, as it increases the pregnancy rate. Endometriosis is associated with the high risk of ovarian breast, and thyroid cancer. In particular, the increase in absolute risk compared with the women in the general population is low, but no significant overall increase in risk. So, which among this is false statement? Put your answers into the chat box. Yes, the answer goes A. The extended administration of GnRH agonists prior to the ART treatment to improve the live birth rate in an infertile woman with endometriosis is not recommended as the benefit is uncertain. There is insufficient evidence to recommend a prolonged administration of COC or progesterone as a pre-treatment to ART to increase the live birth rate. In infertile women with a revised ASRM stage 1, stage 2 endometriosis, clinician may perform IUI with ovarian stimulation instead of just doing the expected management as it increases the pregnancy rate. Endometriosis is associated with the high risk of ovarian, breast, thyroid cancer. In particular, the increase in absolute risk compared to the woman in the general population is low, but no significant overall increase in risk. Clinicians should not routinely perform surgical excision and ablation for incidental finding of asymptomatic endometriosis at the time of surgery. So here the part of clinical governance comes. Once you perform the surgery, though you've seen that there is an incidental finding, do not touch. After the surgery, discuss with the patient, know her concern, whether it is infertility, whether it is a pain or something, and based on that, the further management will be done. So this is as per the endometriosis guideline 2022. A 34-year-old Paris woman was diagnosed with stage 3 endometriosis. She was on GnRH analog for 1 year duration. Subsequently, she had laparoscopic excision of rectovaginal endometriosis. She continues to be in pain despite of medical and surgical management. What is the next most appropriate management option for her? A. Aromatase inhibitor. B. Danazol. C. Long-term GnRH. Progesterone only pills or Tibolone. Answer goes for A. The correct answer is aromatase inhibitor, as aromatase inhibitors are recommended in a woman with a rectovaginal endometriosis which is refractory to the medical or surgical treatment. It can be prescribed in combinations with the hormones or GnRH analog. Question number 3. Mrs. ABC is 35-year-old and suffers from a primary infertility and endometriosis. Her recent pelvic ultrasound suggests the presence of 2.7 cm endometrioma. Her pain is well controlled using the simple analgesic. She is due to undergo IVF. Which treatment is best suited to deal with her endometrioma? Do expected management? Laparoscopic ovarian cystectomy, laparoscopic ovarian cyst aspiration, laparoscopic ovarian cyst fenestration and drainage, and laparoscopic salpingo-oophorectomy. Yes, do the expected management as the size of endometrioma is 2.7 centimeter. 36-year-old para 4 underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy for severe pelvic endometriosis that had not responded to the medical and conservative surgical management. She attends for her follow-up appointment complaining of hot flushes and sweating, that is postmenopausal symptom. Which HRT regime should you consider over here? A continuous estrogen and progesterone in a combination, estradiol patches, oral estradiol valerate, progesterone only HRT, or topical estriol. The explanation is that it is a combination. In a woman with surgically induced menopause because of the endometriosis, the combined estrogen and progesterone therapy or Tibolone can be effective in the treatment of menopausal symptoms. The ESHRE recommends that in postmenopausal women after hysterectomy with a history of endometriosis, clinicians should avoid unopposed estrogen treatment. The theoretical benefit of avoiding disease reactivation and malignant transformation of the residual disease, and however, should be balanced against the increased systemic risk associated with the combined estrogen and progesterone Tibolone. The guideline development group recommends that the clinician continue to treat the woman with a history of endometriosis after surgical menopause with a combined estrogen and progesterone or Tibolone, which is a combination, at least up to the age of natural menopause. Some people do get confused that after performing a hysterectomy, is there is any role of progesterone, but in context of endometriosis, knowing this explanation, yes, it do require an endometriosis patient. Which of the following is a false statement? Laparoscopic identification of endometriotic lesion is confirmed by histopathology, although negative histology does not entirely rule out the disease. B. The diagnostic laparoscopy can considered as a gold standard for diagnosis by endometriosis. C. Women may offer NSAIDs or other analgesics either alone or in combination of other treatment to reduce the endometriosis associated pain. D. It is recommended to offer women a hormone treatment in the form of combined hormonal contraceptives, progestogens, GnRH agonist or GnRH antagonist as one of the options to reduce the endometriosis related to the pain. It is recommended to prescribe a woman a combined hormonal contraceptives in the form of oral, vaginal ring, transdermal to reduce the endometriosis associated dyspareunia, dysmenorrhea, or non-menstrual pain, which is the false statement. The answer goes in favor of B. As we know, the guidelines very clearly mentions about the laparoscopy is no longer considered as the gold standard. How much is the reported risk of ovarian failure after bilateral ovarian endometrioma cystectomy? A 1.5, B 2.4, C 3.9, D 10%, E 50%. And yes, the answer goes in favor of 2.4%. The laparoscopic excision of ovarian endometriotic cyst wall, which is more than equal to 3 cm or 30 mm, is superior to the drainage and coagulation by bipolar dithermy for treating the recurrence of dysmenorrhea, dyspareunia, and non-menstrual pain, as well as reducing the rate of subsequent surgery, while the superiority of the excision over drainage and coagulation ablation might be expected. Concern about the excessive restriction of the ovarian tissue comparing that the future fertility remains with the reported risk of ovarian failure after bilateral ovarian endometrioma cystectomy is near about 2.4%. What is the estimated prevalence of endometriosis in infertile women? Very rightly, we have seen at the first slide. As per the ASHRAE guidelines, the exact prevalence of endometriosis is unknown, but estimated ranges from 2 to 10% in a woman of reproductive age group and up to 50% in the infertile category. So option goes in favor of E. A 35-year-old infertile patient classified as having a stage 1 endometriosis was prepared for the IVF. After counseling regarding the treatment, she asked you some questions. Which of the following statement regarding the IVF is correct? A. Clinical pregnancy rate for IVF is reduced in endometriosis. B. Miscarriage rate is higher than the average in a patient with stage 1 endometriosis. C. Ovarian stimulation could make the endometriosis condition worse. D. The stage of endometriosis has no impact on the number of oocytes produced. E. Studies have shown low fertilization rate in a stage 1 endometriosis. However, the implantation and clinical pregnancy rate are not affected. Yes, so option E. The studies have shown that low fertilization rate in stage 1 endometriosis. However, the implantation and clinical pregnancy rates not getting affected. The level of evidences is 3. The several studies have shown the similar results for the IVF treatment in patients with stage 1 endometriosis compared to other group with no endometriosis. There has no indication that miscarriage rate is increased in endometriosis. A recent meta-analysis of 27 observational studies included 8,984 cases and showed a low fertilization rate for IVF in stage 1 endometriosis. However, the implantation and pregnancy rates were same. Which of the following is not useful in decision making for surgery to treat the endometriosis? A. A family history of endometrial cancer. B. A patient's age and preferences, history of previous surgery, ovarian reserve, and the endometriosis fertility index. So the guideline development could recommend that the decision to perform surgery should be guided by the presence or absence of symptom, patient age and preferences, history of previous surgery, the presence of other infertility factor, ovarian reserve, and the estimated endometriosis fertility index. So to identify the patient that may benefit from the ART after surgery, the endometriosis fertility index should be used as it is a validated, reproducible, and a cost-effective tool, which is as per the ASHRAE 2022 guideline. Mrs. XY with a chronic pain in lower abdomen was found to have an endometrioma of near about 6.5 to 4.5 centimeter. She underwent a laparoscopic ovarian cystectomy and was found to have severe endometriosis. She wants to know the probability of her conception. Which of the following scoring system you will use for the same? Is the revised AFS scoring, or endometriosis fertility index, NZAN's classification, ACFSM scoring system, and can't be predicted. Yes, it is an endometriosis fertility index is a simple, robust, validated clinical tool to predict about pregnancy rate after endometriosis. To identify the patient that may benefited from the ART after surgery, the endometriosis fertility index should be used as it is validated, reproducible, and the cost effective. And this is about endometriosis. Endometriosis, the guideline which is given by ASHRAE, it's quite long guideline. A recent TOG article about endometriosis and fertility, which definitely help you to collectively understand the things in a shorter phase of time. So do read the endometriosis fertility TOG article, or we do have the YouTube video for the same. Let's talk about male infertility. In a patriarchal society, the male infertility is not discussed well, but as a clinician, we need to give the justice to this topic in detail. Male with azoospermia or severe oligospermia, that is severe semen deficit, do karyotyping before you perform an ICSI, as Y chromosome microdeletion is seen in azoospermia and severe oligospermia. Also, ICSI won't allow a chance to do a genetic diagnosis of chromosome disorder. Patient with the congenital absence of bilateral vas difference is near about 10% cases of azoospermia. Anti-sperm antibody seen in 12% of cases of azoospermia. No increase in pregnancy rate following the varicocele treatment has been seen. And patient with azoospermia, it is advisable to do the FSH level so that you will understand whether there is a possibility of sperm retrieval or not by means of procedure called as surgical sperm retrieval. It has been seen that out of 100, 11% patients do come with a karyotype abnormalities and 7% patient comes with a Y chromosome microdeletion. So understand 89% patient will have a normal karyotype and 93% patient have a normal Y chromosome. Kallman syndrome, hypogonadotropic hypogonadism. The treatment is gonadotropin pulsatile therapy. Normal reference value for the semen quality were published by McLeod in 1951. Spermiogenesis, that is spermatic to going into a sperm. Noonan syndrome, it is nothing but the male counterpart in a Turner syndrome. No evidence that the wearing a loose-fitting underwear improve the fertility. Sedentary lifestyle increases the scrotal temperature and so affect the sperm productions. These are the couple of investigations things that we need to aware about a male infertility. The sperm count which is less than 5 million, FSH, testosterone, prolactin has to be done. In a severe male factor, yes, the karyotype also be required. The first go with this endocrine profile followed by a karyotype profile. Testosterone level undergoes the diurnal variations and they are highest in the morning. What are the causes of azoospermia? So it could be a pretesticular, testicular, post-testicular. If it is a pretesticular cause, you could see LHFSH is low, testosterone is low, and in that context, GnRH or exogenous gonadotropin may be useful. Testicular, where the FSH and LH is on a higher side, but it still shows the low testosterone level, and yes, the sperm retrieval after the ART can be possible, or you can go ahead with the donor sperm sample. Post-testicular, having the normal LHFSH and testosterone level, so it is obstructive pathology. So it could be because of the vasectomy, so you can do the reversal of vasectomy or reconstruction surgeries over here. Carnitine, vitamin C, E, zinc, coenzyme Q10 improves the quality of life and the live birth rate. FSH act on the Sertoli cell, LH acts on the leading cell, leading to the testosterone secretion. So pre-testicular less than 1% and post-testicular near about 41%, counting to the causes of male factor. Testicular volume is roughly around 20 ml. The varicocele is more on left side as it directly draining into the vena cava. Semen analysis is not the test of fertility, but as a guide for a minimum standard of adequacy. If normal, then one sample is pretty sufficient enough, but if it is abnormal, repeat the sample after 3 months or early if the initial test shows the azoospermia. The period of abstinence, 72 hours. If more than 5 days, then yes, it decreases the motility of the sperm. If the count is less than 5 million, as I said, do LH, FSH, prolactin and testosterone level. Talking about genetic evaluation, the most common cause in a male infertility comes with a Klinefelter 47XXY. Near about 10 to 15% patients comes with azoospermia and 5 to 10% with severe oligospermia, and both conditions could be possible because of Y chromosome microdeletion. When it comes to the deletions, there are the zone A, B, and C. So if it is a AZFA or B has a very poor prognosis, we do not even offer a sperm retrieval. But if it AZF, then yes, it has a good prognosis. If the vast difference is absent, then advise the renal ultrasound, as 30% male do have the renal abnormalities too. Sperm DNA test for the prognostic value in ART outcome. So it includes the sperm chromatin structure assay, which we prefer, a comet assay, a tunnel, that is terminal deoxynucleotidyl transnic end labelings, and overall pregnancy rate after performing ICSI is 33%. A very important and one beautiful topic, that is about premature ovarian insufficiency. The two concept, premature ovarian insufficiency, is almost similar to the early ovarian aging with a couple of differences. So this premature ovarian insufficiency is defined before the age of 40. The incidence will be seen at the age of 45, 40, 30, and 20 is as follows. So less than 45, it is 5%, less than 41%, less than 30, 0.1, less than 20, it's 0.01. So incidence of POI, please note these numbers very importantly for your exam. It is characterized by a menstrual problem. It could be oligo or it could be amenorrhea. There are certain modified risk factors like gynecological surgical practices, lifestyle, smoking, modified treatment regime for malignant and the chronic diseases. So the patient with oligo or amenorrhea asks for the symptoms of estrogen insufficiency. So how to diagnose the premature ovarian insufficiency? The two things. It could be oligoamenorrhea for at least 4 months apart, or FSH and FSH, which is more than or equal to 25 international unit on two occasions 4 weeks apart. And these two criteria has to be fulfilled to diagnose your patient with the condition premature ovarian insufficiency. The most common chromosomal abnormality is X chromosome. The non-iatrogenic causes of premature ovarian insufficiency. So in that causes, the genetic evaluation is needed. So do the chromosome analysis. If there is a detectable Y chromosome, then yes, it is but obvious to have the premature ovarian insufficiency, and that Y chromosome suggests to opt for the gonadectomy, Fragile X syndrome. So it is nothing but X-linked diseases, and it can causes the premature ovarian insufficiency. An additional reason to counsel about the Fragile X testing is the risk of Fragile X associated tremor, ataxia syndrome, a late neurological problem predominantly in a male carrier of Fragile X mutation. Implication of this Fragile X permutation should be discussed before you perform the test, because it do have the impact for herself and her family member. It is have the autosomal gene mutation. So whenever there is a more than 200 CGG repeat, that is full mutation, it is associated with the mental retardation. When the repeats are between 55 to 200, there is no evidence of mental retardation. Galactosemia, a hypoglycemia of a FSH, it results into the premature ovarian insufficiency, and so the routine screening is not recommended for the same. The premature ovarian insufficiency of adrenal autoimmune origin is the most frequent type, which is observed in near about 60 to 80% of the patient with autoimmune premature ovarian insufficiency. The premature ovarian insufficiency of unknown cause, or if any immune disorder is suspected, then do screening for the 21 hydroxylase antibody, that is anticorticoid adrenal cortical antibodies. Premature ovarian insufficiency with 21 hydroxylase or adrenal cortical antibodies positive, then refer to the endocrinologist to rule out the Addison's disease, and also do the screening for the TPO antibodies if present. Then we have to perform the TSH, that is thyroid test, annually. Expected anti-TPO antibody is near about 12 to 15% in general populations. The guideline development tool considers only diabetes 1 is the important for the premature ovarian insufficiency, because it diagnosed many years before the premature ovarian insufficiency. As diabetes mellitus 1, as it is adolescent and childhood onset, So there is no indication to do the screening for the diabetes mellitus in premature ovarian insufficiency. So the autoimmune polyendocrine system, there are two types: type 1, type 2. Type 1 is autosomal recessive, type 2 is autosomal dominant. Type 1 is associated with the AIRE gene, and the type 2 is associated with the HLA locus. The incidence of type 1 is near about 15% in premature ovarian insufficiency, and type 2 is near about 10% in premature ovarian insufficiency. So if the patient is having the adrenal cortical antibodies or anti-TPO antibody, refer to the endocrinologist. He will do ACTH, he will do a plasma renin activity and ACTH stimulation test every 5 years interval, as well as the thyroid, vitamin B12, ferritin, folate to diagnose the pernicious anemia or celiac disease. If there is no signs and symptom of disease, no need to do a retesting in a later life. No need of to do the any screening for the infections too. Talking about premature ovarian insufficiency and the Turner syndrome. So need to get a cardiac opinion, as it inherently have the risk of aortic dissection near about 11% and the bicuspid aortic wall near about 16%, and it may develop the hypertension also. So the pregnancy with the Turner syndrome, the maternal mortality is 3.5% has to be discussed with the patient. Premature ovarian insufficiency associated with the increased risk of premature death because of the cardiovascular diseases. So it is always advised not to smoke, have a regular exercise, and maintain a healthy weight. Can patient with a premature ovarian insufficiency get pregnant? Yes. There is 5% chances that yes, these patients do get pregnant. If not planning for a pregnancy, it is always advisable to have a contraception till 2 years since her last menstrual period. Premature ovarian insufficiency, there is no intervention is reliable to increase the ovarian activity and natural conception rate. Female considering the oocyte donation from oocysto, then it is carries the high cycle cancellation rate near about 5-fold, because she might having the genetical inherited pattern of the insufficiency in the phase of time. Anthracycline, it's a cardiotoxic. So 25 milligram per meter square to 300 milligram per meter square is the dose. Female with a oocyte donated pregnancy, there is a high risk of antenatal clinic to get visited for the high risk reasons. According to the UK HIFA, indicates that the oocyte recipient have almost two-fold increased risk of preterm birth and low birth weight. Noted, it's preterm birth and low birth weight compared to the female using their own oocytes. It's one of the SBM in the one of the exam. Aneuploidy related to the age of donor, not to the recipient. Spontaneous pregnancy after idiopathic premature ovarian insufficiency or after most form of chemotherapy are probably not at risk of general population. Premature ovarian insufficiency with donated oocyte gifted pregnancy results into the IUGR as one of the more common thing. Nice preeclampsia is at risk to start the ecosprin from 12 weeks if there are the two or more moderate risk factor or one major risk factor that has to be calculated when you are prescribing the ecosprin for the preeclampsia as per the NICE guideline. When it comes to the Turner syndrome or patient who has already taken the anthracycline, which is one of the cardiotoxic, yes, refer to the cardiologist. Aortic dissection cutoff as per the ASRM, above which the pregnancy should be avoided, is near about 2 cm per meter square. Note this value very importantly. Before oocyte donation, full investigation including thyroid, adrenal, and karyotype to be done. Premature ovarian insufficiency, do check for the blood pressure, renal function test, liver function test before you come to the pregnancy. The bone mineral density more than 2.5 standard deviation and the t value less than minus 2.5 suggestive of osteoporosis. And if the t score is between minus 2.5 to minus 1, it is osteopenia. So recombinant nutritional requirement is 1000 milligram per day for a calcium and 800 international unit per day for vitamin D. Note this numbers very importantly. Selective estrogen receptor modulator, that is raloxifene, associated with the increased risk of hot flushes, VT, but a decreased risk of invasive breast cancer. Strontium granulate, for the treatment of severe osteoporosis if alternatives are not available, but not allowed for a patient with heart or circulatory problems. The Frax tool, it calculates 10-year probability of major fracture, which include the hip, lumbar, humerus, wrist, and lower age for this tool is 40. And this tool considered the current history of smoking, not a past history of smoking, which is very important the SBA for your exam. Measure the bone mineral density at the initial diagnosis of premature ovarian insufficiency, and if it is diagnosed, the estrogen replacement treatment. Repeat the bone mineral density 5 yearly. If there is a decreased bone mineral density, then reassess the estrogen replacement regime and you can come to the conclusion. If there is a surgical menopause in next 3 months, then there is a chances of increase LDL and lipoprotein and decrease HDL is noted. HRT start early in premature ovarian insufficiency to control the future risk of cardiovascular disease. It should be continued till average age of natural menopause. The premature ovarian insufficiency with the cardiovascular risk monitor to be done by the blood pressure, the weight, the smoking, and SOS or other risk factor as an annual basis. If there is a Turner syndrome, then do monitor about the cardiovascular risk, check for the blood pressure, smoking, weight, lipid, fasting blood sugar, HbA1c on an annual basis. The quality of life assessment instrument by WHO include the physical health, psychological status, the level of independence, the social relation, and environmental features and the spiritual concern. The strong predictor for the post-surgical menopausal health is previous mental health. The low sexual desire, despite of adequate estrogen replacement, may benefit from the short-term use of testosterone, which is 300 microgram daily, but not on the long term, is unknown. Estrogen replacement is adequate and necessary to prevent the cognitive decision or low cognitive function in a spontaneous premature ovarian insufficiency, but it may not be effective for a female with Turner syndrome as the cognitive functions may remain despite of treatment. Hormone treatment up to the age of 50 may be good for neurological function in female who have early menopause, but after 60, it adds to the risk of dementia and the vascular diseases. Tell female with a premature ovarian insufficiency that HRT may not be found to increase the risk of breast cancer before the age of natural menopause. The breast cancer risk is high with the continuous combined regime than the cyclic one. If you have a premature ovarian insufficiency and a history of VTE, thrombophilia, refer to the hematologist before you start the HRT. The androgen treatment for 3 to 6 months, not beyond 12-month duration. 17 beta estradiol is more physiological. Cyclic HRT is most preferable for female with premature ovarian insufficiency. The cycle length maximum up to 12 weeks to decrease the endometrial risk of hyperplasia and malignant changes to be noted over here. If you are thinking about a cyclic HRT, transdermal estrogen is preferred route. The microgenized progesterone protect the endometrium and is best with the oral cyclic combined treatment. If you are having the POI with established HRT, then review annually. HRT is contraindicated in the breast cancer survivor. HRT is treatment option in a female with BRCA1 BRCA2 mutation without personal history of breast cancer after prophylactic bilateral salpingo-oophorectomy. Migraine is not a contraindication to the HRT in POI patient. If migraine worsens with the change the dose and route, then transdermal you can opt for that. The transdermal has a lower risk. Hypertension is not a contraindication for the HRT in a premature ovarian insufficiency. You can use the transdermal estradiol. It also preferred in a VTA risk patient. A last topic, that is early ovarian aging. Low ovarian reserve at a younger age and accelerated loss of follicles in early 30s. 20% female with fertility have the early ovarian aging. Younger females with early ovarian aging have a less time to accumulate the DNA damage and the oocyte number lost more rapidly than the quality. And that's the reason the early ovarian aging is something, a battle of quality owes the quantity. Though the quantity is less, but the quality is maintained or up to the good mark. The quality of oocyte in a female with the early ovarian aging is relatively preserved. So natural conception is possible and the success following ART is really good. So management, a female who is less than 35 years with a low antral follicle count, the per cycle success rate is near about 15%. Live birth rate per treatment cycle using the autologous frozen thaw oocyte in United Kingdom is near about 18%. DHEA, dihydroepiandrosterone, used in IVF outcome with low ovarian reserve associated with the increase in the clinical pregnancy, live birth rate, and along with that, a decrease in miscarriage rate. Oocyte quality decreased from 31 years of age The age of menopause hereditarily constitutes near about 35 to 80% of the cases. So this is the differences between the early ovarian aging and the premature ovarian insufficiency. In a clinical practice among the subfertile population, I'd be happy to treat the early ovarian aging patient because these patients really have a good quality of eggs. Early ovarian aging, 10% prevalence. Premature ovarian insufficiency, 1% prevalence. Early ovarian aging patients are asymptomatic with a regular period. The premature ovarian insufficiency patients have symptoms or of estrogen insufficiency. They do come with the oligomenorrhea or amenorrhea, one of the diagnostic criteria. You could see the FSH level more than 25 international units 4 weeks apart on two occasions as one of the marker, but in early ovarian aging, the FSH is normal or mildly elevated. Estrogen replacement not indicated in early ovarian aging, but again in premature ovarian insufficiency, it is advised. Fertility is preserved and delayed in early ovarian aging, and in premature ovarian insufficiency, the chances of natural conception is near about 5%. Couple of questions. Early ovarian aging, which of the following is incorrect? 10% prevalence, regular period, asymptomatic, FSH normal or mildly elevated, estrogen replacement indicated. So the answer is about E. So estrogen replacement therapy is not indicated. Premature ovarian insufficiency, which of the following is not correct? 1% prevalence, oligoamenorrhea, may have other symptoms of estrogen insufficiency, FSH is markedly elevated, and the chances of spontaneous conception 15%. Obviously not, it's near about 5%. So that chart is very, very important. The diagnostic criteria for premature ovarian failure or insufficiency. As per the current ASHRAE guidelines, the oligoamenorrhea for at least 4 months, elevated FSH, 25 international unit, 2 occasions more than 4 weeks apart. B, oligoamenorrhea for at least 4 months, elevated FSH more than 40 on 2 occasions more than 4 weeks apart. C, oligoamenorrhea at least 6 months and elevated FSH 25 on 2 occasions 4 weeks apart. D, oligoamenorrhea for at least 4 months and elevated FSH more than 25 international unit 2 occasions 6 weeks apart. E, it is a oligoamenorrhea for at least 6 months, elevated FSH level more than 25 international unit on 2 occasions 6 weeks apart. A, the option is A. It's a rule of 4, the 4 months and 4 weeks. Note it clearly. Screening of high-risk group for premature ovarian insufficiency includes fertility, poor response to the ovarian stimulation, a family history of earlier premature menopause, history of ovarian surgery or treatment for cancer such as chemotherapy or radiotherapy. All of the above? Yes, it's all of the above. Heritability of age at menopause has been seen in how much percent of the patient? It's near about 30 to 85%, suggesting a significant contribution from the non-genetic factor, particularly the uteroendocrine and nutritional environment. Coming to the closure of the session, determination, efforts, and practice are rewarded with the success. A few days, and yes, the exam will be done. You'll be coming with a flying color of success, and very soon you'll become a member of Royal College of Obstetrics and Gynecology. Thank you for your patience hearing. Wishing you all the best and good luck with lots of love and happiness from Dr. Dinesh. Stay tuned with Team Study Medics for your exam preparation journey.